Hello, everyone, and welcome to our lunchtime webinar, where we're going to try to answer the question, will patients benefit from the Inflation Reduction Act's maximum fair price? My name is Ryan Gough, and I am the Executive Director of the Partnership to Advance Cardiovascular Health, or PATCH. Now, as a quick programming note, you'll find just below the live stream window a Q&A box to submit questions, so please feel free to submit questions, and we will work them into the program as we can. Thank you. PATCH is a nonprofit coalition of 20 member organizations that work together to advance public policies and practices that increase access and innovation for cardiovascular patients. Since 2016, the Partnership to Advance Cardiovascular Health has worked to lift both patient and clinician points of view directly into policy conversations across all 50 states and in Washington, D.C. Since the passage of the Inflation Reduction Act, or the IRA, PATCH is focused on whether or not the legislation will live up to its promise. The healthcare provisions in the law alone promulgate some of the most significant changes in how healthcare will be delivered in our country. So it's important that we get this right. There are many pieces of the law that we have championed as patient-friendly, but there are two major facets for concern that we have addressed with both the Centers for Medicare and Medicaid Services and with federal legislators. One facet is centered on the research and development impact of the law. We believe that the IRA will uniquely impact cardiovascular research and development negatively, and we have since championed the MINI Act as a narrow fix to incentivize continued development for cardiovascular medicines that use genetically targeted technology specifically. A paper our coalition commissioned from Avalier discusses that topic thoroughly, and you can find more information on that below the screen in the show notes. Now, the other facet concerns access. Though there are many provisions in the law that in theory should improve affordability and access to therapies that will become subject to Medicare's drug price negotiation program, there has been significant hand-wringing among advocates, policymakers, and policy organizations that there may be some significant unforeseen challenges or consequences ahead. Now, this is a complicated topic, and I am grateful to have two folks on the line who are smarter than me to shed some light on what we as a community of advocates and patients may be facing. To help guide us through this difficult topic is Dr. Robert Popovian. Dr. Popovian is a healthcare and biopharmaceutical leader accomplished in pharmaceutical science, business, and government, with a distinctive array of academic and practical experience across a wide range of healthcare and business management functions. Dr. Popovian is currently the Chief Science Policy Officer for the Global Healthy Living Foundation and the founder of Conquest Advisors. Dr. Popovian, thanks so much for being here.
Thank you.
We're also joined by Dr. Ann Sydor, the Director of Research, Development, and Communications with the Global Healthy Living Foundation. Dr. Sydor earned her BS in molecular biology from the University of Wisconsin and her PhD in neurobiology from a university you may have heard of called Harvard University. After completing her formal education, she continued learning across many areas of clinical medicine as a publisher of educational medical content. Through her role as a parent and care partner and personal experience with migraine and depression, she has become a passionate advocate for person-centered medicine, health equity, and positive uses of technology. Dr. Sydor, thanks so much for being here with us today.
My pleasure.
So, Dr. Popovian, this is a complicated topic, and I want to get to the kind of the basics here to really get us started, to really lay a foundation for our audience. So, in 2022, President Biden signed the Inflation Reduction Act into law, which included a number of provisions that changed the benefit structure of Medicare Part D. Can you explain to our audience, can you almost give the pitch for how this law is supposed to benefit Part D beneficiaries?
So, Ryan, thank you for having me here. We've spoken quite a bit about Inflation Reduction Act since its passage and implementation. Just like any complex, large legislation, there are positives and negatives that will come out of it. And there are significant positives for patients through this legislation. For example, there's a cap with regards to the Medicare part for patients with regards to their out-of-pocket costs for Part D. There is zeroing out any kind of cost sharing regarding Medicare Part D vaccines for seniors, which is significant. Leveling, which is the law requires that patients are no longer hit with a huge sum in the beginning of the year that they can basically pay over time, over the 12 months, their out-of-pocket costs. So those are significant positives, and there's also the positive of moving liability to the PBMs, which traditionally in Medicare Part D, the liability has rested with either the federal government or the pharmaceutical industry, actually. So those are good things, but like anything else, there's some negatives and potential negatives. One of the biggest negatives that we've seen, you brought up it early on, is the impact on research and development. Without a doubt. I mean, if you look at Congressional Budget Office all the way to private sector analysis, R&D is going to get reduced in the United States. Specifically, the threat of reduced R&D concerning small molecule is real because of the way that the law was written. And legislators and policymakers need to go back and change that if they really want to preserve the innovation that we're going to come see as it is. The second part that is also concerning is the access issues. And we'll get into more details why we believe at Global Healthy Living Foundation and other organizations like the Pioneer Institute, as well as other organizations I represent, we're very concerned about that because at the end of the day, there is no guarantee through the IRA that any of the savings are going to be shared with the patient at the point of sale at the pharmacy. And that's a major concern that every patient and every patient organization should have, because at the end of the day, is the government going to save money? I have no doubt about it. But are patients going to save money? That is highly questionable at this point.
So, Dr. Popovian, can you, just as level set two, can you explain what's actually going to happen or what's happened with this negotiation process a little bit? So there are 10 different medications that were chosen by Medicare, and they've been going through this negotiation process. So can you just level set for us exactly what's happened over the course of the last year or so?
So exactly, and we're gonna basically, there was an announcement a couple of hours ago that the maximum fair price disclosure is going to come out for the first 10 drugs on Thursday, which is not surprising because they want to get the maximum bang for their buck before the Democratic National Committee meeting, which is next week, I believe. So what the government has done is they call it negotiation, but it's really price setting. So they've set prices for the first 10 drugs that were chosen based on various parameters that they were set up through the legislative effort, which had to do with the highest expenditures that they had in Medicare Part D. So these drugs are for treatment of cardiovascular disease, diabetes, arthritis, so on and so forth. So we're going to see that maximum fair price set on Thursday and what it is. We are also going to see whether or not, what is the parameters that CMS is going to look for regarding formulary design and everything else. That's still to come. There's less clarity on that, how CMS is going to regulate that. And that's our concern. As you mentioned, the access issue is something that is an unknown. And I can go into more details exactly why we believe that PBMs are going to do something different than what currently is in the marketplace.
So just to reiterate there, so the maximum fair price is essentially for the first kind of 10 drugs that Medicare has chosen here, which, by the way, 5 of the 10 are cardiovascular medications. So, this has major implications for cardiovascular patients and those that are writing these prescriptions. So the maximum fair price is essentially what the government has decided they're going to pay for these drugs. Is that right?
That is absolutely correct. And Ryan, you have to remember that when a pharma company sells a brand drug in the United States, 50% of the revenue gained from the price of that medicine is captured by the supply chain or the middleman, whatever you want to refer to. And the majority of that is captured by the pharmacy benefit management companies and the insurers because they're one and the same now. So 50 cents out of every dollar sold goes to someone else besides the pharma company. So imagine this now. Because of the price that is set by the biopharma company, now that price is going to be lowered. And the way that the PBMs and insurers work with pharma companies is that they negotiate prices based on rebates, and they take fees from the pharma companies and concessions. If you lower the maximum fair price, what you're potentially doing is also reducing the profitability of the PBMs. Because if you have a $100 drug and you're reducing it based on rebates to $50 and concessions, that $50 primarily stays with the PBM as profit. Now, if you reduce that price from 100 to 50, even if you give a 50% rebate and concessions back to the PBM, their profit margin is dropping significantly. And we believe that PBMs are going to start looking for other opportunities to be able to gain back that profit. And remember, when patients show up at the pharmacy counter, they're paying based on that retail price. So they never see any of that concession that has been given to the PBMs at the point of sale. So in other words, PBMs are going to look for other places to gain their profitability back. They're not just going to sit back and say, okay, we're going to make less money tomorrow than we did last year. And this is where I think you're going to see a few things. One, they're going to tap into therapeutic areas that traditionally they have not engaged in. For example, vaccines. We've already heard they're trying to get concessions on vaccines, which really doesn't make any sense because nobody pays for vaccines out of pocket in the United States. So it's not to the benefit of the patient, it's to the benefit of the PBM to make more money. The second part we've seen, and we potentially are going to see, and this is why we did the study that Anne is going to discuss, is that we believe that access is going to be reduced for patients through formulary changes, whether it's going to be elimination of medicines off formulary, there's going to be administrative burden put on, or as our study looked at, what is the potential of just subtly increasing out-of-pocket costs for patients and what are those consequences? Mm-hmm. And this is what Anne and I have studied through the Global Healthy Living Foundation, and we have a study that she will discuss in more detail.
So let me back up a little bit, Dr. Popovian, and see if we can, really make this simple for folks. So, if I look at this at, face value, if the government is now going to set the price for a specific medication, one would assume a voter, a patient, a citizen would think that the price would come down for the patient. So you think, okay, this thing that I get at the supermarket or the pharmacy is normally $10, but the government's now saying that they're only buying it for $5 now. So you'd think that you could go to the pharmacy or the supermarket, and pick it up for $5. But what you're telling me is that is not what we're going to see here with the MFP.
Well, the patient, there's no guarantee that the patient is going to see the savings, and the MFP is going to help patients a little bit if they have a deductible or co-insurance, because now they're going to pay based on that lower price, right, of MFP rather than the initial retail price. But our worry is this, that they're going to make subtle changes in the benefit design, that they're going to recoup that money back from the patient somehow. And we found some very interesting data to show that they have a lot of wiggle room that CMS, Center for Medicaid and Medicare Center, that is not really going to have access to. And even if they have access to that data, it's going to be retrospective. That means that the patient is going to end up paying for it, and then CMS has to make adjustments. So that's our concern. It's not the overt law. The overt law looks good, right, Brian? You lower the price, patient shows up at the pharmacy. If they have a deductible or co-insurance, they're paying based on MFP. But our worry is that there's enough flexibility within the tiered model of a formulary that the PBMs will start playing around with out-of-pocket costs, not overtly apparent to regulators, and therefore they will be able to recoup that money from the patient.
Okay, got it. So, Dr. Popovian, thank you for explaining the kind of ecosystem within which all these changes are taking place. And I think that's a good segue to Dr. Sydor and the discussion of this research that you referenced that you've both taken on looking at the specifically the anticoagulant class of medications that are on the list of 10 original negotiated drugs, where we'll see the MFP. As you said, I guess you said this, it will be announced on Thursday. So this is serendipitous and timely webinar. So what's fascinating about this work as I was reviewing it is that what, Dr. Popovian, what you outlined is how those of us who understand kind of the drug supply chain assume or anticipate would happen potentially with these medications. But in the study that you all conducted, you take real world data to show how the marketplace pressures might impact actual patients. So Dr. Sydor, what your study did, if I may, was look at price setting of the two major anticoagulants on the market that are on the list of 10 original drugs that are subject to the MFP, and then estimate the potential out-of-pocket increase and the downstream effects of such an out-of-pocket increase if that were to take place. Is that a fair characterization? And can you provide a more accurate color on that?
That's a very fair representation. And this is a study that was done by Dr. Popovian, Esteban Rivera, and myself at the Global Healthy Living Foundation. What we did was look at a couple of the anticoagulants and how those are currently being reimbursed by insurance and pharmacy benefit managers, or paid for by those parties, and what would happen if that was shifted. So we started with the number of prescriptions for anticoagulants, apixaban and rivaroxaban, which are the most widely prescribed at this point, that are brand name drugs. And these are prescriptions covered by Medicare benefits. This data is supplied from pharmacy benefit managers back to the drug manufacturer through a third party. So this is the data that says, here's the prescriptions that are being managed, and here's the amount that patients are paying. What's really interesting is that the data that's provided back on this is very broad strokes. There's not a lot of detail in it. CVS Caremark managed about 11 million prescriptions, Optum Rx managed about 7.8 million, and ESI managed about 4.8 million. All three major formularies have these anticoagulants in tier 3 or tier 6 of the formularies. And just to level set for people, tier 1 is generally the generics, tier 2 is what you pay a little bit more for, maybe a more expensive generic, and tier 3 is generally where you start to see the brand name drugs. What was interesting is that within these tiers, we saw that patients could be paying anything from $0 to over $200, whether their medication was in tier 3 or tier 6. And so really, it's not about the tier. It's about the benefit design that states exactly what the patient's out-of-pocket costs for their medication are going to be. So within a range, for the three major PBMs, 18 to 27% have zero out-of-pocket costs for either one of these anticoagulants. 26 to 31% are going to pay up to $50 for their anticoagulant prescription. And then it starts to get interesting. For CVS and Optum, 25 to 30% of patients are paying $50 to $100, and 20% are paying over $100. But in the Express Scripts data, only about 7% are paying $50 to $100, and 40% are paying more than $100. So what this really tells us is that no matter what the tier, different proportions of patients are paying different out-of-pocket costs that range from 0 to 200 plus. And this gives the insurance company and the pharmacy benefit manager a lot of leeway to shift the amount that patients are paying, not based on tier, but based on individual benefit design. And we use that wide variation to estimate some changes in out-of-pocket costs. We can talk about that, but let me first ask if you have any questions or want to bring up any points about that initial data evaluation.
So let's back up a little bit, Dr. Sydor. So I think it's important for people to understand that there are these things called tiers, that are part of a formulary. So can you, just real quickly, and you touched on this, but explain what a tier is and kind of how people normally think about tiers.
Right.
And we'll complicate that in a moment and get more to what you found within what's happening within those tiers. But can you explain exactly what a tier is for folks on the line?
Sure. So let's go back even further and say, what's a formulary? A formulary is a list of drugs that an insurance company, and as Robert said, the insurance companies and pharmacy benefit managers are now really one and the same because they're owned by the same parent companies. So the pharmacy benefit manager, your insurance company, puts out a list of drugs that they will or will not pay for. Drugs that are excluded, they won't pay for at all. Drugs that are included, they require patients to pay a different proportion of. That might be your copay, it might be your co-insurance. But patients, when we go to the pharmacy, the pharmacist doesn't just hand us our prescriptions and say, oh, here you go, your insurance covered all of it. They charge us what our share is. And it's the formulary and the tiers on the formulary that supposedly determine what we pay. So again, a generic drug is tier 1, almost always, because it's going to cost a smaller amount. A more expensive generic, something that's a little newer, might be tier 1, and the expectation is that patients will pay more for that. Brand name drugs, the newer drugs, the expectation is that patients will pay even more. So as the number of the tier goes up, the patient's share of the costs goes up. Generally, you would think that that's based on prices going up. We've done some work on formularies, exclusions and inclusions, and see that that's really not the case. It's based more on the amount of rebates and concessions that a pharmacy benefit manager gets from the drug manufacturer. But the key thing is tier 1 through tier 6, increasing costs for patients.
So Dr. Sydor, what your analysis did was look at where the drugs sit as on a tier 3 currently, and then you moved it to another tier to see what the cost sharing difference would be theoretically. So can you talk to us a little bit about what you found there?
Sure. So the way we modeled this, and again, what we found is that as much as the expectation is that costs go up as the tier number goes up, what we also found is that the range of costs within a tier is very, very wide. So even if a drug is tier 3, patients might be paying over $200 for it. 10% of patients will be paying more than $200 for it. Even though a drug is tier 6, 10% of patients will be paying less than $50 for that. So what we had to do was we had to take the midpoint of that range within tier 3 versus the midpoint of the range within tier 6, based on how patients are distributed across that. And comparing the midpoint to the midpoint, what we saw was a potential cumulative increase if the 3 largest PBMs were to move apixaban and rivaroxaban from tier 3 to all tier 6. It could be an increase of $359 million for apixaban and $149 million for rivaroxaban. And that's the increase in the share that patients would be paying. So ultimately, if lowering the manufacturer's list price reduces the money going to PBMs, they can make up that difference by having patients pay a larger share, potentially a combined $500 million more paid by patients.
So that's an enormous amount of money that will be shifted, that could be shifted to patients under this scenario. So, but what we care about, number one, obviously, if out-of-pocket costs go up and cost sharing goes up for patients, that's going to change behaviors. So you looked at that as well. So what happens when potentially the costs go up for the patients or the cost sharing goes up for patients? What do you find happens?
Sure. Well, I don't think it's a surprise to anyone on this call that when the cost of a patient's medication goes up, their adherence to treatment goes down. There is a linear relationship that's been examined in a study by IQVIA that, again, wouldn't surprise any physician or clinician, that as the copay amount or out-of-pocket costs go up, the number of patients who stop using the prescribed medication also goes up. So we used that linear relationship shown by IQVIA and applied it to the data we had for apixaban and rivaroxaban. And what we see is changing these drugs, these anticoagulants from tier 3 to tier 6 could lead to 321,000 people abandoning treatment with anticoagulants. So that's a lot of people giving up a medication because of a shift in costs.
Well, and we know that with the anticoagulant, class, it's obviously one that you cannot stop therapy. And we've seen this with switching that's occurred within the class over the last few years. So once those abandonments go up, what do we see in terms of events that occur? Do you have any sense of that?
Based on the published literature studies of what happens when people do abandon treatments with anticoagulants, we see some pretty concerning increases in morbidity and mortality. We see a 45% increased risk of major cardiovascular events. We see a 30% increased risk of all-cause mortality after abandoning anticoagulants. We use those numbers to estimate that there would be 76,000 to 103,000 more major cardiovascular events for patients who abandoned apixaban, and 32,000 to 42,000 for patients who abandoned rivaroxaban. That's an increase in all-cause mortality projected at 72,000 to 97,000. So we're actually talking about a pretty high increase in mortality for patients. For cardiovascular physicians' patients, people will get sicker and more people will die without treatment. There's a reason cardiologists prescribe these medications. There's a reason they want their patients to adhere to treatment. And when you raise the costs, what you do is you prevent patients from getting the treatment that they need to live their best lives.
So, Dr. Sydor, just to thank you for that. I think there's one question in the chat I wanted to throw to you. Someone asked, was this study done looking only at Medicare beneficiaries, or was there other types of insurance included as well?
This was only Medicare beneficiaries. So so that's looking just at people who have Medicare Part D. There, of course, are lots of people with private insurance who are using these anticoagulants. We did not look at that data because the IRA is not negotiating the price for that. It's just negotiating the price for Medicare beneficiaries. We do see that insurance companies tend to reimburse both treatments, procedures, and medications at the same rate that is set by CMS for Medicare beneficiaries, though. So I think we could see similar findings in people with commercial insurance. We just wanted to be very specific and limit this to the IRA when we did the study.
Right. Makes a lot of sense. Okay. So Dr. Sydor, Dr. Popovian, I think, your research is really impactful and interesting because it illuminates, as Dr. Sydor, as you really pointed out, starkly there, the potential unintended consequences of these policy changes. And if you were to ask, I think, anyone in the Biden administration or at CMS if this was like a foreseen potential outcome, I think they would probably answer no. And of course, no one wants any of these outcomes for vulnerable patients that need to be on therapy. I'll just say Patch and many of our partners have spoken directly to CMS about our fear of a scenario like this. But those concerns initially, were based mostly on our understanding of just the kind of the drug supply chain that Dr. Popovian really outlined at the beginning, and our understanding of how medicine is really delivered in this country. But your study really puts a finer point here on what could happen and why that might happen. So really appreciate your thoughtful work on this. The question, though, Dr. Popovian is, and I'm sure a lot of people are online asking this themselves is, well, what do we do about this? What do you do about it? So what question? So, you're the policy expert. What do we need to do to make sure that this doesn't happen? And as these changes are pushed through CMS, and what would you kind of impart upon the advocates here on the call, how we should kind of go about our interface with CMS and other bodies that matter here.
So in my opinion, what has to happen is that advocates such as Patch and other organizations, Global Healthy Living Foundation, the physician organization, the pharmacy organizations, whoever's working on this, is to really pressure CMS to do a holistic evaluation of these formularies and not just what they're looking for. Because I'm going to firmly believe that no PBM or insurer is going to eliminate these drugs from the formulary because of
Right.
MF. I also don't necessarily think that they're going to move tiers. That means I don't think that they're going to move to tiers from patients on tier 3 to tier 6. We just use it as a surrogate to demonstrate the impact of our study. I truly believe, though, that there's so much leeway within each tier that you will see subtle changes in the out-of-pocket cost for patients that will impact an adherence. So, for example, because we saw a majority of patients, for example, paying under $50, easily the PBM can move those patients to a $50 to $100, which is a subtle change, which will not be visible to anyone because they didn't change a tier, they didn't eliminate the product from the formulary, but at the same time, they put out-of-pocket pressure on patients, which will force them to abandon their medicines. And remember, we're talking subtle changes, which is not easily found. And a lot of these changes will be found retrospectively. So CMS not only needs to look at these formulas prospectively, but has to look at it retrospectively and has to do more of a micro level analysis of each formulary, which I don't think they're doing. They're just looking at the big picture, right? They're looking at, okay, the formulary for 2024, did it eliminate any medicines from the formulary? Did they change any tiers? I'm not certain that they have the capability or the willingness to really look within each tier to see what the differences will be for patients. And I think that's the biggest question that we need to do and pressure CMS to do that as advocates. Listen, Ryan, we've been in this game for a long time. PBMs are a very profitable part of the healthcare industry, more profitable than any other segment of the healthcare industry. Mm-hmm. And frankly, they're not going to give up revenue because of MFP, because I truly believe it's going to put pressure on their profitability and walk away from it. They're either going to do what Anna and I have studied, subtly change the formulary design to put pressure on patients. Second, they're going to do what they're already trying to do, which is go to revenue to other models like vaccines and things to gain revenue from them, which again, it's going to impact your cardiovascular patient because frankly, that patient requires the vaccine. Or the third part is they're going to put pressure through the insurance or through PBMs on either pharmacists or physicians about reimbursement. So one way or another, they're going to recoup their profitability. And I firmly believe that they're going to do all three of them. But the most concerning one is this changing benefit design for patients, because if they do subtle changes that is not visible, patients can have consequences, and the consequences in this therapeutic category especially are dire.
Right. Well, I think that, yes, absolutely, Dr. Popovian. I think what's really fascinating. So I would say the most surprising thing from the research that you've done, and there was a question in the chat, is how do we share this information and get this out? But I think that the thing that you all found that's the unsurprising thing is we know that the PBMs are going to try to find savings somewhere, and they're going to push cost to patients. I mean, we understand that, and we all now also from your research know, if you increase the out-of-pocket cost for patients and the cost sharing for patients, they're going to stop taking drug, and when they stop taking drug, you're going to increase the likelihood for events like that. That is confirmatory, but not surprising, right? What is surprising though is you're seeing that within the tiers that there's actually no what would you call it? There's no I'm losing a word here. There's no consistency of what people are actually paying, right? So and
that's exactly right. The tiers are defined by the individual insurance plan, and a pharmacy benefit management company like CVS Caremark that currently has 30% of people paying $50 to $100 could shift that so that only 10% of people are paying $50 to $100, and 40% are suddenly paying more than $100 versus the 20% that pay more than $100 now. That wouldn't even be a change in tier. That would just be a minor shift in benefit management that could double costs for patients. So here they are being told, isn't this great? Prices are going to be limited and they're going to come down and there's going to be savings, and their share could actually go up. And for cardiologists, I think the key take home from that is that when patient costs go up, their adherence goes down, and there are cardiologic consequences.
So that was the aha moment, frankly, from this study. If anything that came out, which Anna and I were like, okay, this is where they're going to play the game, was that within the tiers, the subtle changes that they can make. And because the way, and this is another thing Anna and I recognized quickly when we got the data, because of the way that the data is reported back to pharma companies and probably CMS, they give it in these buckets, right? They don't give individual like patient level. They give, well, a certain percentage are paying between $50 and $100. Well, they don't tell you if they're paying $51 or they're paying $99, right? $50 and $100. So they can quickly shift. If a lot of patients are paying 51, they can quickly shift them to 99. You won't even see the data coming back will be any different, but the patient will feel the difference at the point of sale at the pharmacy. So that's my point, is that CMS needs to do a micro level analysis of these formularies and not just look at it very perfunctory in the beginning to say, okay, bless it and move away because they didn't make any changes.
Right. So we can't actually understand the true patient impact unless we're looking at that micro data instead of looking at the broad tiers, is what you're saying.
Exactly. That's another thing. I mean, there's so much, those were the aha moments for us that we realized, because initially our thoughts were, oh, okay, we're going to get on tier 3, everybody's paying $25, and tier 6, everybody's paying $100+, and they're going to move everybody to tier 6. No, I don't think that's going to happen. I truly don't believe that. I think they're going to keep everybody in tier 2 or 3, wherever that tier is, but they're going to make subtle changes within the tiers, which is not going to be visible to anyone but themselves because the way they report the data back to the pharma companies.
Got it. Extremely helpful for advocacy purposes. So Dr. Popovian and Dr. Sydor, can you share anything about when the fulsome study will be published, that kind of thing for folks?
And you want to talk about it, where you have it available and publication?
Sure. So the study is actually available now on the preprint server, medarchive.org. And we can share a link for that with people in the chat. And we are submitting it to peer-reviewed journals for publication and expect that would happen over the next couple of months. That's just kind of the way the research cycle works. But because of what an urgent and timely issue this is, we do have it on the preprint server. It hasn't been peer-reviewed yet, but we trust that our audience can bring their own diligence to evaluating how the study was done.
So we will send out that link to everyone who registered for the webinar. So we'll get that out for folks for you all. So thank you. So Dr. Sydor, Dr. Popovian, can't thank you enough for joining us today. As we said, this is a timely webinar. Did not realize it was as timely as it's going to be. We advertised this as a lunchtime webinar. I hope everyone had a light lunch because it's some pretty heavy discussion. Very important though. Thank you so much for joining us. We're going to continue to advocate for affordable access to care and welcome anyone who's watching to join us as we work to ensure that patients can get the medicine that their clinicians prescribe. Because as our panelists showed today, the stakes really couldn't be higher. So thank you both for being here, and thank you all for joining us for today's program. Take care all.
Thank you.
Thanks for having us.